Welcome, everybody. This is the monthly psychedelic support speaker series, and I'm your host, Dr. Allison Fiducia. Without further ado, I'm going to introduce our speaker. We are honored to have Dr. Adele Lafrance join us today. She is a clinical psychologist, research scientist, author, and developer of emotion-focused treatments modalities. She is active in research and practice with psychedelic medicine with a focus on ayahuasca, MDMA, psilocybin, and ketamine. She has a particular interest in mechanisms and models of healing, including emotional processing, spirituality, love, and family-based psychedelic medicine, which will be our topic for today. About how can we include family and those significant others to support individuals who are undergoing psychedelic therapy. And I also want to mention a really interesting project she has going right now. She's an investigator on the Love Project, which is working to bring attention to the science of love in psychedelics, therapy, and healthcare. And so this is going to be a threefold survey, which includes qualitative interviews and interviewing people that have experience with psychedelics where love was a central theme. I'm going to go ahead and drop her website and a link to this Love Project. So if you're interested in learning more about that, you can check it out in the chat. So I'm going to hand it over to you, Adele.
Thank you so much. It's really nice to be here with you all. And I love the feature of people writing in from where they're from. So that is lovely. I see some familiar names in the chat as well. So happy to be here with you for the next hour, especially talking about this topic. And just really appreciate, Allison, you inviting me to talk about this. So we'll get started without wasting any time. I'll just tell you a little bit about my background and how I came to be interested in this topic of family matters and psychedelic-assisted therapy. When I first started working as a psychologist, I began the development of a new treatment model called emotion-focused family therapy. And it's not your typical family therapy. It's a treatment model that is more consistent with what's being called community-based healing. So it's a paradigm where close others are recruited into care and they're offered support, but also skills so that they can support their loved one in the home. And so for the last decade, I've been working on emotion-focused family therapy and implementing it, researching it with parents, caregivers, spouses, other close others, and seeing how we can help them to help support their loved ones and how that can actually lead to improved outcomes for everybody. So that was very much, my first passion and my first real strong area of focus as a psychologist. And then a few years into that, I was introduced to psychedelics totally by accident. I was a university professor, and I was, working on EFFT and its application to hard to treat conditions. And I came across a documentary with Gabor Mate, got in touch with him, ended up working with him for a while. And that really just snowballed, into being involved in all kinds of research studies and clinical opportunities with ayahuasca, with MDMA, with psilocybin, and with ketamine. But because of the origins of my work, supporting family members, close others to support their loved ones who were struggling, I always had a mind to the integration of those two worlds. And so over the years, I've really focused quite a lot of time, energy, and clinical attention on blending the two worlds. Like, how can we take what we've learned from family systems, from community-based treatment models, and integrate that within these paradigms of psychedelic medicine. And so I have had the opportunity in the last 4 years to work in research and or clinical settings where we do just that, where we blend what I've learned over the years with respects to systems and family involvement with different compounds. Was a co-PI on a study at Cedar Psychiatry with ketamine, where there were this new model that I developed called emotion-focused ketamine-assisted psychotherapy, which involves elements of emotion-focused therapy, but also emotion-focused family therapy, where there was a supportive person involved. Imperial College, I'm a supervisor and trainer on a study for psilocybin for anorexia, where there is EFFT and support person involvement. And then working on the development of a protocol for MAPS, where there is a dedicated portion of the research protocol focused on a supportive other, a close other. So I'm really excited about that, because what I've learned so far from my personal healing experiences, from my clinical experiences, from my involvement in science, is that when we are treating a person, it's wise to regard that person as if they were a blooming flower connected to their family plant in a garden, which represents their chosen family. So we often talk about the illusion of separation in terms of awakening to the illusion of separation can actually be quite healing, And I feel like in the field of psychedelic therapy, we are still a little bit blinded, by this illusion of separation, given how most treatment models are being delivered, in terms of being focused specifically on the individual with very little or no formal involvement of the people in their system. So my strong feeling is that we need to work towards decolonizing therapy, psychedelic therapy, in the way that it's highly, highly focused on the individual. That's just not how healing is optimized. Healing is optimized when we consider the system, whether we involve other people in their system deliberately or we support them indirectly. And I'll give you examples of what that is. And so really moving away from, or awakening, from this illusion of separation, working towards decolonizing therapy, and making it far more systemic in terms of how we operate. And that's whether someone is receiving ketamine-assisted psychotherapy, attends an ayahuasca, psilocybin, or an ibogaine or iboga retreat, or participates in medicine research, with LSD or psilocybin or MDMA, what have you. So that's kind of the backdrop. And so I'll give you a composite case example. So as I mentioned, I've provided training and supervision to a number of different people and organizations over the years. And so I put together this case example to illustrate some of what I'll be talking about today, including some solutions. So as a result of his participation in a psilocybin study, Aiden realizes that he's been suppressing healthy anger for decades and that it's hurt him in many ways. When he makes contact with this sacred anger, reckoning with its beauty, he is eager to engage with this new internal resource in his day-to-day life. Post-session, Aiden is encouraged to be careful with how much he shares, including with his partner, until his experience is more fully integrated. He does, however, begin to assert himself in a way he's never had the courage to do before, and it feels authentic, aligned, and vital. The problem? His partner is freaking out. She shares her concerns with Aiden. She's worried that the therapy is making him worse because of all of this anger and these boundaries, and she also feels alienated by the process and certainly not valued as a resource. She starts to question the safety of the medicine and the soundness of the study, the protocol, and the therapist. She doesn't know what to do, and she's spinning. Aiden is now really worried that this is evidence that the relationship isn't right or won't survive, that she can't tolerate or support his new healthy expression of assertion. So I have seen this quite a number of times over the years. And it can be a problem that can be not just solved, but prevented. And so offering you solutions is, part of this webinar today. So let's first start with just some rationales for the recruitment of active engagement of close others. And a close other could be a parent, it could be a sibling, it could be a partner, spouse or partner. It could be a close friend, so the close other is broadly defined. It's defined by the person who is undergoing the healing, so seeking care. So here are a few rationales. So first of all, close others are an untapped resource to support the preparation, integration, and healing processes in general. So what I've found in clinical practice, but also supported by research through the years of working on emotion-focused family therapy, is that when we involve close others, even in really, really small ways, like imagine 15 minutes part of the prep session, it can optimize outcomes for everyone involved. And when you look at community-based healing paradigms, it really rests upon this foundation. So Indigenous healing traditions absolutely support this rationale. Neuroscience absolutely supports this rationale in that if I am seeing someone for therapy and I use therapeutic techniques with them, it should work, but if I teach their spouse or partner how to do some of what I do in session, even if it's just validation, then their partner or spouse's efforts are going to have way more of an impact than mine because of the theory of interpersonal neurobiology. They're more connected than I am, who's, a relative stranger. And then, like I mentioned, research that's been conducted with like family-oriented therapies, remember family is a broadly defined term, shows that it leads to better outcomes for everybody, not just the person seeking care. So it leads to improved outcomes for the individual seeking care, as well as improved outcomes for the system, which I think is wonderful. And, parents, caregivers, romantic others, friends, they can learn skills and they can be involved in really, really significant ways. What we found is that most of the time they just need a little bit of support and a little bit of skills training, to be able to know what to do and then do it outside of in the home environment. So the second rationale for the recruitment or the active engagement of close others is that when we are bonded with someone who's going through a very rapid metamorphosis, it actually can be really challenging and disruptive for us. When people engage in psychedelic medicine, they absolutely can impact their system or their significant other in really significant ways. They might open up some strong emotions that linger for days, weeks, or months. They might re-experience memories. They might get messages from the medicine for their partner or about their relationship, or even just like a new way of being will disrupt some of the old patterns, which can cause stress for the system. The other piece is that their close other, the person who is being impacted, may be in a really tough time in their life. They may not be feeling very resourced, or they may just be blindsided, by what's happened. And so it made me really kind of think about this idea of consent. Like, if my significant other goes on an ayahuasca retreat for 2 weeks, my life is likely going to change in some positive ways, but also some potentially quite challenging ones, until the teachings or the healings are fully integrated. And so it's like, my partner doesn't need my consent to heal, But there is something there to be said about preparing the system and spending time, focused on considerations of this nature. This tends to be more true when people are living together. There's much more of an impact. Like, some people can come back and be like, oh, I can't watch the news anymore. I'm like, oh, we had this. Well, I watch the news every night at 6. So what are we going to do about this? So it's just even little things that we don't consider can be challenging. And so a little bit of prep support for the close other, a little bit of integration support for the close other, even just a warning, can really go a long way. And then the third rationale that I'll focus on for today is that receiving someone post-experience is also a skill, that needs to be cultivated. So many times I've heard anecdotes from people who said, oh, I went home and I talked to my partner, friend, parent about some of the things that were revealed to me, and they got defensive and they questioned my involvement, with these medicines, et cetera, et cetera. It's actually really, really, really normal, at least in North American culture, that when someone brings to us something difficult that involves us, that we respond with defensiveness. We've basically been conditioned very broadly to do that. So that's one example. Another example is if, like I said, someone comes back home and they have a lot of strong emotion that's very difficult for them to process. Being able to receive that, being able to offer support is a skill, that needs to be cultivated. And I've heard people related to the Heroic Hearts Project, like they're doing some good work helping to prepare the partners and spouses, of the individuals who are going for healing to be received. Whether it's 1 hour, 1 day, or 1 week post-experience, it is oftentimes a delicate time for the individual who had the experience, during which there are some unique needs. And so if we resource the system, then again, we increase the potential for positive outcomes. We decrease the potential for unnecessary suffering if they get caught into culturally conditioned dynamics, or unique dynamics to their relationship. And then there's, again, the potential of shoring up, supporting the evolution of the system, as a whole, as an organism or as an ecosystem. So what's needed in the field, in my humble opinion, I do feel like there's a major and problematic gap in terms of the availability of support for close others before, during, and after the medicine experiences, and whether it's directly, in terms of them being involved in some way, or indirectly. And I'll give you an example of indirectly. I attended a 1-week healing retreat without medicine here in the US, but it's a well-known retreat that often leads to really significant transformations for people. And as part of the preparation materials, I was provided with a letter to share with the closest people in my life. And that letter involved, a heads up about what could happen and what could be needed when I came home from that retreat. And I was like, wow, that is so simple. It's indirect and yet so powerful to prepare the system. And I mean, I could talk about this topic literally for 2 days. I'm going to be doing a 5-hour training in the fall, with a lot more information. So it is very much a big layered topic. But my hope is that you might feel inspired by any of what you hear today, and that might lead to some potential evolution in your practices or in the practices of the people around you. Because, when there are gaps, there are also opportunities. There are so many opportunities for people in the field to support clinicians, guides, to be more systemic, in their delivery of psychedelic medicine. So in the last couple of years, I've developed a tripartite model for family-based intervention. So there's 3 different models are for family involvement in the context of psychedelic medicine. Model 1 is family-supported psychedelic-assisted therapy. So we recruit a family member, and again, the term family is broadly defined, and we offer them skills and support so that they can be an ally as their loved one evolves with therapy. The second model is where family members are taking medicines together. So for example, I did something like this with ketamine, and so there's really specific protocols that I've developed that aren't the be all to end all. And then the model 3 is surrogate healing, where there was a young woman who was medically unstable, wasn't able to use medicines, but it was in quite a compromised situation, mentally and physically. And so one of her parents decided to participate in psychedelic therapy with the intention of surrogate healing, which was really, really beautiful. So for today, I'm just going to talk about model 1, family-supported psychedelic-assisted therapy. And so this model, as I mentioned, involves the recruitment of a family member or a close other who is supported by the guide or the therapist to support their loved one throughout the course of the work. And we offer them psychoeducation, we offer them emotional support, but we also offer them skills training in the hopes that doing so will create a more optimal home environment for healing and growth, will reduce the likelihood of problematic relational patterns that could interfere, and will bring meaning and healing to the whole system. And so I've really been lucky that I've been able to apply family-supported psychedelic-assisted therapy in the context of 3 different research protocols, one with ketamine, one with MDMA, and one with psilocybin. In fact, if any of you are going to the MAPS conference in June, we'll be presenting some data, some themes from a study that was conducted at Imperial College, where there was a close other that was recruited in this way in the context of a psilocybin study. So here are some highlights from the research protocols, from practice as well, that I'll share with you in case any of it feels like it's doable for you to integrate in the work that you're doing or that you will be doing. So in terms of preparation, when we work with a close other, what we found could be really helpful is providing the rationale for the healing work, which seems really, really simple, but can go a long way in terms of helping them to connect with meaning for the work. So then, and if they see that it's like, oh yeah, it's meaningful, I get it, then they're more encouraging of the work, they're more supportive of the work, they're less uncomfortable, with the work. Then we also provide rationales for the support person involvement. So I have a big spiel of like many, many reasons, why we want to encourage that support person to be involved. And again, it's meaning making, but it's also empowering, it's respectful, it's loving. And so in particular in this one study that we did with ketamine, like it was just so lovely to see the family members kind of light up, when we talked about like how important their role could be and how important they were because of the loving relationships between them. And so it really helped elevate, their motivation to be there for their loved one. We provide them with education about how healing can disrupt systems because it can interfere old patterns of relating to one another. That healthy anger can often arise and how good of a thing that is, but how uncomfortable it can be at the beginning, because at least in North America, many of us are quite uncomfortable with expressions of anger, even healthy expressions of anger. And then we give them a heads up about having to renegotiate what we call unconscious contracts. And I'll give you an example of that in a little bit. And then lastly, in the preparation phase, we provide skills. We provided specific, easy, concrete, emotional support skills, so that when their loved one had emotional experiences, that they could feel more comfortable going to their family member, going to their close other, especially knowing that their close other learned some ways to attend to them in a good way. In one of the studies, we also provided dosing support. So we invited a close other caregiver to be involved in the pre-dose work, or to even offer support during the dosing session. And we had a little handout about like words that you can say or ways to engage with your loved one using touch if they're having a hard time, which of course, all of that is reviewed with the individual receiving the medicine to make sure that that feels good for them. And then offering them support skills post-dose on how to receive your home or your person as they transition to home, in very practical ways, but also, emotionally. And then finally, post-dose, we work with the system to develop a systemic conscious post-dose share protocol. So those are really fancy words to say that we figure out what the person who had the experience is going to share, how much they're going to share, how they're, when they're going to share it, etc. So that this system is prepared for it. And I'll actually speak more about that in a little bit. And then lastly, offering of post-dose support to the caregiver, to the family member, to the close other, including integration support for them. I envision a world where, as we advance with psychedelic medicine, we have dedicated integration groups for close others, who have not used medicines, but who have been affected by medicines in significant ways. So it's not here. I'm no longer talking about like how they can support their loved one. It's like, no, how they can receive support as they move through these sometimes challenging upgrades to their relationship. And in some cases, medicine work leads to relational breakdown, and that can be really, really hard. So I don't know if any of you are maybe interested in spearheading that kind of work, but there's a huge need for that. And that need is only going to become greater in the future. And of course, I add HIJ, all these other ideas that are not elaborated in this talk or have not yet been elaborated, that will be able to help the delivery of this work, especially as it evolves. So how is the work implemented? Again, I'll just offer you suggestions from what we've already done in clinical practice and in research. So close other attends a prep session with their loved one. Maybe they attend another one on their own. For the Imperial study, we put together an educational video as well. So all of the close others were able to watch this educational video and what to expect and how they could, have a role to support their loved one. The close other can also attend an integration session with their loved one and another one solo. They can be provided with personal support over the phone or in session as needed throughout. The person receiving care can also relay information and education to their close others. So that's the indirect way of implementing a more systemic approach to psychedelic healing, plus many other possibilities. So I'll just say a little bit more about these two components of preparation. Actually, I think I'm just going to talk about one of them. And then I'll give you a little example of a systemic conscious post-dose share protocol so that those of you who are here today can actually leave with some new skills potentially. So here we go. So we inform the system, we inform the person receiving care and their close other that healing can lead to the disruption of systems. Most often it does. And that could also include what we call the renegotiation of unconscious contracts. So this is a form of inoculation. We let them know what's going to happen so that when it does happen, they're not as scared of it. They knew that this was going to happen in the context of healing. And so what is an unconscious contract? Well, an unconscious contract is basically an agreement that we make with our close others. That's not necessarily spoken, but that's pretty set. For example, an agreement could be, we don't talk about anger, or we don't criticize each other. Or an agreement could be, we don't talk about hurt with each other. Or an agreement could be, you make me feel special and I'll make you feel cared for. So it's actually quite fascinating when you start to look at unconscious contracts with people. Like, oh, in this relationship, the unconscious contract is we focus on the positive. And medicine work doesn't want an unconscious contract that's not serving us to survive, so it like shines a light on it and makes it conscious, which then means that it needs to be renegotiated. And I've seen many people see the light and commit to showing up differently, but without informing the other. And so then the other is like, wait a minute, that's not how we do things. And when there are hiccups, then the other person might be like, oh, well, maybe you're not the right friend for me. And it's like, whoa. No, we just need to renegotiate consciously for both parties, these unconscious contracts. And so I put together a little script that people can use, and you're welcome to screenshot it and copy it. Not a problem if you find it helpful. So here's an example of someone who did psychedelic medicine and who realizes they need to show up differently with certain people. And so here's the person speaking to their sister, Catherine, let's say. Catherine, I wanted to share with you that through the work I've been doing, I realize that I don't always open up to people about how I feel or what I need, most often to avoid stress or distress in my relationships with people important to me. I see, though, that this isn't serving me, and it's sometimes hurting me to keep so much inside. I'm learning that I need to start showing up in a different way in relationship with others, in a more authentic, truthful way, even though it's intimidating. I want you to know that our relationship is one of the most important relationships I have. I love you so much. I know you love me. For this reason, I'd like to start to practice being more authentic in the context of our relationship, with the hopes that these efforts will eventually transfer over to my other relationships too. That being said, when I start to be more honest about how I feel and what I need, especially when I'm upset about something, it may come off as too much, or it may be so tentative that it's hardly noticeable. I'm going to be working to develop these skills, and I know that can only come with experience and practice. I would really appreciate your support in helping me to get there, even though it might be awkward, difficult, or just really different than what we've been used to. And then here is another version. I've also started to consider that we sometimes engage in patterns of avoidance when it comes to some topics or feelings. I see that these patterns have been helpful to some degree, especially because, it's been a tough time for us these last couple of years. It feels like it might be time for us to try figuring out these more delicate topics so that we can grow together. And so, there's just, people use these scripts and they adapt them, they make them their own, but it really, really helps to bring consciousness to the changes, in particular, the systemic changes that are necessary for healing. And then when we couple the heads up about the renegotiation of unconscious contracts with providing that other person with skills to respond to challenging material, challenging emotions, including healthy anger, then we're really, really, creating an ecosystem that should optimize outcomes. So you can see I get excited about it because it's just such a big difference than just going in cold and be like, I saw this in my psychedelic therapy. This is not okay. This can't happen anymore. This is so much softer and integrated and hopefully supportive of all people who are involved. So here's an example of the emotional support formula that we teach close others. So we teach them to convey understanding of their loved one's experience and demonstrate that attempt to understand using 3 because statements, followed up by an emotional support sentence and a practical support suggestion. We practice it with them a few times. I'm making it sound more complicated than it is, but here's an example. Okay, someone responding to anger. So the person undergoing the psychedelic medicine has gotten in touch with sacred anger. We've prepped their close other to be able to receive their expression of anger. And this is what it looks like. I can understand why you'd feel angry, because this is not how you wanted it to go. And because you might feel like I don't get how hard it is. And because we butt heads often about this issue. I'm committed to finding a path forward together. I love you. I'm not giving up on us. Why don't we take some space, collect our thoughts, and try again in a little bit? So this may not seem like a big deal, this little script, but it can be so powerful and so different from baseline. When someone comes to us and says, I'm mad at you, the first urge, even myself, is like, why? Or it's not rational, but I didn't do it on purpose, And what we know from neuroscience is that validating the reasons why it might make sense for the other person to feel angry is very soothing for the brain. And it creates an optimized brain that facilitates healing, not just internally, but relationally. And so, we teach this structure and we have them practice with different situations that they think may come up or that did come up and they didn't know how to handle, and they would like to go back and try again. So let me talk a little bit about the elaboration of system conscious post-dose share protocols. So this is, for me, it's quite an interesting topic because I think one of the most common instructions in terms of what to share and how much post-medicine experience is to be mindful, be mindful of what you share and how much. And there are many benefits to this approach. I've uttered these words many times myself. In fact, one of the metaphors that I use is that we've just put down wet cement. And so you want to be careful not to let anyone trample on that wet cement. You want to give it some time to harden. You want to give yourself time to integrate your experience more fully. So yeah, a lot of benefits to this approach, but there are also risks. And I feel like the risks maybe aren't discussed often enough. And so I don't know if any of you are familiar with the still face experiment, but it's a classic psychological experiment where a mom and an infant are engaging with each other, really sweetly, how they normally do. And then the mom is instructed by the researcher to turn away and then to come back again, but with a still face. So no nonverbal whatsoever, and also no verbal communication. And the infant notices right away and then tries to connect with mom, by being cute. Oh, hi, what's there? Not with words, but with vocalizations and with gestures. And then mom remains still. And the poor baby gets so upset, gets angry, gets sad, gets really, really scared to the point of losing her posture. It's a classic video that you can Google on YouTube, the still face experiment. And what this experiment is meant to show is that when people who are close, who are neurobiologically bonded, come together, and there is a lack of reciprocity in communication, verbal and nonverbal, that actually it can be quite distressing for the system and for the other person, the dyad. And that's not just true for babies and their mothers. When one person is bonded to another through family relationships, through romantic relationships, or in friendship, and that person withdraws or withholds intimacy, the other is likely to act out. It's a very predictable neurobiological process. And so imagine someone just comes back from an MDMA session as part of a research study. And they tell their partner, yeah, it was really powerful, but I can't talk about it right now. I mean, more often than not, it will lead to an anxiety response in the other. And then if the other doesn't feel supported, they might not feel regulated enough not to act out that anxiety. And so to avoid that unavoidable suffering for both parties, what we can do is talk about it. It's like, okay, this is a common process. If your loved one comes home and decides that it's not the right time to share, just want you to know that may cause anxiety within you. You might feel anxious about being left out, or you might feel anxious that something came up about the two of you that wasn't positive, or that is a threat to the relationship. And so how can we set it up so that you both are able to have your needs met in some way? So maybe the family member already has set up that they have support with the clinician, therapist, or a friend, if they feel activated when their loved one comes home. Or the loved one who went through the MDMA experience may decide to share some parts, the parts that feel good to share, the parts that feel right to share, so that there is some exchange, so that there is some reciprocity, there's some opening, and then that can make the other person feel okay, even if it's just like, it was, really hard, but really positive. I feel hopeful, if that's true. But as a rule, I'll recommend that the person who engaged in the medicine work share the things that feel comfortable within a structure of that being received by the other in the way that feels best. So for example, we might say to the family member, like, limit the number of questions you ask, or ask permission, to ask a question, so that they can decide ahead of time, what's the protocol? Is it listening or is it discussion? Some people are like, oh, I totally feel wonderful talking about all of this stuff with my loved one, like it feels really important to do that. And I can do it in a loving way. So we provide education related to this process. We elaborate ahead of time a share plan that takes into account these processes, but also, maybe both parties' needs. It doesn't mean that they have to meet each other's needs, but if we have awareness of what their needs are, then they can activate other resources to meet those needs. Okay, so remember Aiden and his partner. So had they been prepared for what was to come, education regarding the protocol, what to expect, the potential importance of renegotiating unconscious contracts, the health of anger, and the provision of skills to his partner to respond to it, the protocol for the sharing process, integration support for her, there may have been, quite a different outcome. And so, in the time that we have left, I'll just say a few more things. Like, I invite you to think about how you can decolonize the psychedelic medicine that you offer or plan to offer, in terms of moving away from a more focused, more of a focus on the individual versus a focus on the system. And so I encourage you to be inspired by any of what you heard today, and to bring in your own creativity to consider how you might be able to live some of that theory or some of those principles in the work that you do or will do. I would say, though, be mindful of your own biases. Sometimes if we have unfinished business with a parent, or even with our partner, spouse, or ex, that can come out in how we support people in medicine work. And so I'm just a real strong advocate for supervision and ongoing personal work, whether it's with medicine or not, so that we can continue to be aware of our biases and reduce their impact on our work. If you do want to consider a more systemic approach to your practice, invest in additional training and supervision, including how to conceptualize and attend to people who are resistant to having their others involved. So I do a whole training on how to move through that kind of resistance. And I'll highlight 2 upcoming opportunities where we flesh out so much more of this. So next month in June, I'm going to be doing a 2-day training on emotion-focused family therapy, which is really the impetus for me in terms of bridging these 2 worlds. So it's a 2-day clinician training, June 2nd or 12th and 13th, and CE credits are available. And then in September, I'm going to be doing one specifically to psychedelic therapy, where I'm going to be offering, theory, but also skills and tools that you can integrate in your practice. And with both trainings, you'll receive many resources, and none of which are copyrighted. You reuse them as many times as possible. We just want to improve the delivery of mental health services, inclusive of systems, inspired by Indigenous models of healing and community-based paradigms. One last note before we close. I just want to say something about teenagers and couples. So more and more I'm seeing, especially with ketamine, that adolescents are being supported with psychedelic medicines. And I would just caution people that if you are going to be working with adolescents with psychedelic medicines, that in my opinion, it's imperative that you have training in family matters, because they are navigating very delicate processes of separation and individuation. Most often they live at home. They're dependent on their parents, and the health of their relationship with their parents is directly related to their health. And when people who don't have training in systems theory or in family work with teens, they can be tempted to encourage a separation from their parents that's maybe not healthy or too soon, rather than using the tools, the techniques to help bring healing to the relationship in a way that supports separation and individuation. And again, that's especially true if you still have unfinished business with one of your parents. My capacity to support teens navigate these processes was directly correlated with how resolved I was with, unmet wounds or unmet needs and unhealed wounds with my own parents. And so I just want to put that out there. And then likewise, and it was highlighted in the composite case example of Aiden, if you are providing psychedelic medicine to one member of a couple, of a romantic relationship, if you unbalance a couple relationships, by fostering asymmetry of growth from treating just one person, especially with potent medicines, because, they tend to lead to more rapid change, it can lead to worse outcomes for the other or for the relationship, including leading to a total breakdown of the relationship. So this is not new knowledge. This is very well known in the couples therapy literature, where if one person in a couple decides to do individual therapy, the odds of the couple splitting dramatically rises, and again, I've seen many times where there's a couple and one of the people does medicine work, the other person's not ready yet for whatever reason, and they come back and they show up in these new ways, they want to talk about these new things, and the other person in the couple doesn't have support or skills to meet them, and then it's like, oh well, obviously this person isn't right for me, or obviously this person isn't supportive of my healing and growth. And I'm like, no, this is normal. This is predictable in our culture. And so we can, as facilitators of this work in those situations, we can influence what's called iatrogenic divorce, therapy-induced divorce. So a therapy that didn't take into consideration what the system needed in order to support the change. And we don't want to rationalize this. We don't want to be like, oh, well, that the other member of the couple just wasn't ready or just wasn't supportive enough, or I guess they just weren't meant to be. That might be true, but I feel like we should not jump to that conclusion if we haven't engaged in active ways to support the system, to support the change. So one last rationale of the involvement of close others before we move to questions. Close others have the right to support. So I worked for many years in the field of eating disorders, where I saw the impact of chronic health and mental health on the family. It reorganizes the family. It influences interactional styles. It has an impact on people's experience of burnout, of quality of life, And so if we determined who is involved, in supporting the person we are giving psychedelic medicine to, and if we determine who's involved based on who's the most resourced, then we are contributing to the reinforcement of structures of oppression, actually. And in the UK, it's really fascinating. In the UK, if you care for someone who has a chronic health or mental health issue, if you care for someone for 2 hours a week or more, then there is legislation that protects you and your access to services and support. So when I went over to the UK to do some training with the team there, I asked them, I'm like, what do you do if the adult client doesn't want their family member or their spouse involved? And they looked at me like, what? Oh, no, there's legislation to protect them, that at the very least, they are entitled to a needs assessment. And we are so far from being aligned with that systemic paradigm and that appreciation that when someone in our system is really struggling, it impacts us too. That I think there are just so many opportunities for us to course correct, especially in the field of psychedelic medicine, because there's a far greater appreciation for the illusion of separation and the need to focus on systems. And so if we are committed to healing from the impact of colonialism, problematic individuality, then for all of the reasons I've noted, including, these ones, we really have to reimagine an alternative to individual models of psychedelic therapy and just individual models of psychotherapy, period. So, thank you. Thank you very much for being here, for listening to all of that. Hopefully it touched you in some way to consider, the way you move forward with your practice. And yeah, we'll take a couple minutes for some questions.
Wonderful. Thank you, Adele. I learned so much, and particularly with psychedelics, this focus of family and collective healing is so important.